Can go ahead and turn the recording on. Good. Yes. All right. So we'll have the recording on. And I can share screen now.
Yes.
Thank you. Um, okay. Everybody can see my screen. Is that correct?
Yes.
Yeah.
Okay. All right. Good morning again. So just kind of give you a quick rundown. You saw the agenda that was sent to last night or early this morning. From admin. It's essentially what we're going to be doing between now and 12:30 p.m. And we're going to try as much as possible to stick with time because I really would want to make sure that when we get to item on the strategizing for teamwork that we have, that will do justice to it, when we get here. And Raven, we're going to need your facilitation or to weigh in when we get to that, because that's when we talked about the what do you call it, the elevator speech. Part of it will be part of that strategizing when we get here. Dr. Adeniyi will be joining us about 10:30 approximately to do his piece. We'll take a short break about 11:25 for about 5 minutes, and then at 11:30, Dr. Olivia Kasire from the Sacramento County Public Health Public Health Officer will be our guest speaker. And the plan is for her to speak for about 20 minutes or thereabout, and allow the rest of the time for Q&A. In other words, there will be other people expected to join us at that time. So what I would like you to kind of think about what kinds of questions that you may want to ask her as it pertains to your work in outreach as community health educator. And then, of course, we'll usually close with have a prayer to close. So, does anybody have any questions so far? You can use the you can use the chat or definitely speak directly as you wish. We did modify this, from save life to save lives. I think the feedback we got recently suggests that we're better to change it to save lives. It rings better. It seems more encompassing and appealing. Direct appeal. So that's pretty much that. Okay. I'll come back to the screen share later on. So again, you're very welcome. Those of you able to join us, I appreciate your stepping in to serve in this very critical role. As you know, this is a project that is intended to promote vaccine outreach, targeting people of African descent or the African diaspora in the greater Sacramento area. Thanks to the support of the grant from the California State Government Operations Agency, as well as very steady support from the Sacramento County Public Health Department. All those that have been working on this project, the managers, the coordinators, the admin, have been great. Mrs. Ojingwa, whom you've been hearing from and will be hearing again from, has been wonderful. I appreciate that. And Ms. Raven McCullough just joined us, or is joining us as our communication marketing specialist. You'll be hearing from her as well. So you're very, very welcome. As we progress today, and definitely on the 29th, you will hear and see the other people who are involved in this project, including those, especially those to whom you will be providing the data and or reporting directly in terms of the organizational chart. Our field services coordinator, Dr. Duru, and he will be interacting with this group on the 29th, and Mr. Kwame Tambo, who is in charge of our evaluation and data collection. You'll be hearing from him as well. So stay tuned, and I want to this to be as collaborative as possible. This is the first time we are running this project. We believe we have a good plan, but that does not mean that we have it in a perfect state. I think part of the improvement is the feedback that you provide us as we move along. So please don't hesitate. Okay. So let's quickly do some introductions. Name, organization, education background, profession, work, as the spirit moves you. If you can do that, that'd be great. Please, who wants to go first?
I can go first.
Please go ahead.
My name is Raven McCullough. I'm a marketing specialist. I currently work for ESPN Radio in their sports and marketing division. I have a communications degree from University of Georgia, and I'm happy to work with everyone.
Thank you very much, Raven. Okay, next, please.
I can go next. My name is Oyinlola Obatulu. I just recently graduated from UC Irvine with a degree in Bachelor of Science and a minor in Public Health. Now I'm just interning for the Birthing Project, and that's what I really do as of right now. And I'm glad to work with everybody as well.
Thank you very much. Appreciate that. Next, please.
Yeah, I'm next. This is Tendai Kombo. I just graduated from Sac State with a bachelor's in public health. My concentration is public health administration. So I'm actually currently working for Dignity Health in one of their specialty clinics. And I'm happy to be here and advancing Ubuntu. Thank you.
Thank you very much. Next.
Okay, I'll go next. My name is Cecilia Ngozi Ojingwa. I am the administrative manager and coordinator for Africa House Sacramento. I am also a teacher, and I'm here if you need me in any way to support you in whatever you're doing.
And a minister as well.
Yes, of course, I'm a church minister.
Thank you. Next, please. Hello. Next, please. Go ahead, anybody.
Don't be shy.
Good morning, Dr. Denny.
Good morning.
Welcome. Hello. Dr. Denny, go ahead. You want to introduce yourself, please? Or reintroduce yourself.
Sure. So I'm Hakeem Adeni Jr. I am a family and community medicine physician. I currently serve as the medical director at Sacramento Native American Health Center, and I also chair the California Primary Care Association's Supporting Black Communities Working Group. And I'm serving as a medical specialist for this COVID initiative through Africa House Sacramento. So I'm very excited that everyone's here, and I look forward to the conversation that we have as a result of this.
Thank you. Who is next? Who would like to go next? Go ahead, introduce yourself, please.
Is everybody? I know Erica did mention that they are having orientation and she's shuttling between this and that, so I don't know.
Okay. Okay, who do we have on
Okay, somebody just in Nwamaka just mentioned that her audio is off and she's trying to fix it.
Is anybody else on we haven't gotten to besides those two, Erica and Nwamaka? Or is that pretty much it? Okay. All right. Because while we're doing that, if you're able to, I don't know why the others haven't joined. If you're able to email them and say we are the process, the training has started, that'd be great. Yeah.
Okay.
Yeah, with the link. Yeah.
Okay.
Okay. All right. Let's do opening prayer. Minister Chungwa, can you lead us before you do that, please?
Okay. Lord, Father, eternal King of glory, we thank you. We thank you this morning for all that you have been doing in our lives, in our communities. Father, we ask that you be with us this morning as we discuss and come up with ideas and solutions to the problems that are facing our community, especially with this COVID-19 pandemic. Father, eternal King of glory, we pray that you give wisdom to the trainers to bring up wonderful ideas that they will give to the people that will be the field workers, the health educators that we have to train this morning. Father, we ask that you give them wisdom, give the community educators to be the passion and commitment to do a wonderful job. Father, we ask that everything that we do will bring glory to your holy name and empower our community to be better, even more united.
Yeah, I think you like this one.
And more we ask in Jesus' mighty name we pray.
Amen. Thank you very much, Mr. Chungwa. Thank you. Okay. Can I go through the key roles and responsibility of the community educator? If you're not speaking, if you'd be kind enough to mute so that we minimize any noise in the background, that'd be appreciated. As indicated in the call for or the application for this particular position, when we talk about community health educator for this particular project, is a conscious effort or decision by the task force to adopt an empowerment strategy that people, when they are educated, are made aware and in an empathetic way. They are likely to understand the benefits of the COVID-19 vaccines and the importance of the vaccination. It's not to shame, it's not to bully, it's not to harm anyone, but to really say in the spirit of Ubuntu, as a community, as a collective, we are dependent on one another and each other. And so your role as a community health educator is primary role is to communicate that and convey that. It's not to suggest that you are going to be a medical expert on the vaccines. However, you need to be able to provide key information that is available out there, and definitely even better than anybody else that has not gone through this type of a training. More importantly, be able to refer those that may have more detailed questions beyond your knowledge. I wouldn't say expertise, your knowledge, to the appropriate sources or resources. And that's one of the reasons we have our medical specialist for this project, Dr. Adeni, who can help respond or direct or refer as the case may be. So really is to influence. As a vaccine influencer, it really is to persuade, is to educate, is to make aware. It's not to force, it's not to impose, it's not to shame, it's not in any way suggest that somebody who who has not received the vaccine, or who isn't maybe even opposed to the vaccine, is evil or somebody that needs to be punished in any way. You will find different levels of resistance or hesitation or hesitancy towards the vaccine. people that we believe are reluctant or hesitant because they have some good questions or things that they can that can be addressed and as a way of influencing them, right? But there are people also who are out there who are saying, you know, I'm opposed, or I'm anti. And you can listen to such and then make a decision in terms of maybe moving on. And maybe even if you say, okay, this is a material you have, when you have the time, take a look at it and maybe they could change their mind. But the most important thing is that we have this forum through February, through the education town halls, through the other work that we'll be doing in terms of your direct outreach for people who want good information, to want to get the facts, to be able to do that. Where appropriate, refer them to clinics or medical professionals or resources. Basically serving as a street outreach worker, you know, meeting people where they are, their homes, places of work, in the public places, private places, and of course, do that with utmost respect and safety at all times. In target or assigned zip codes, which you'll be hearing more from next week, what those zip codes are. In Greater Sacramento area, Sacramento County, extending up to Davis in terms of Yolo, up to Stockton in terms of San Joaquin, and of course, Placer, counties. So the Greater Sacramento area basically is what we're talking about. We are hoping that we can do the assignment so that people will be given certain zip codes and based on either place of work or residence. And approximately 3 to 5 hours a week is what we're looking at. And that will be, in terms of meetings with individuals, families, group or groups, community, private, public places, and so on and so forth. And your contact will be via email, phone, in person, at events that may be going on, canvassing with door hangers, as the case may be. And we're looking at basically you being able to reach 10 to 20 people a week over 20 weeks in between October of this year and February 2022. And then be able to report the data. And again, next week we'll talk about what kind of data we're talking about. Okay. And whatever you do, safety always. As I mentioned, you are an independent contractor. We trust your judgment that you will be creative, you will be innovative, you will be adaptable, you'll be responsive in what you do and how you do it. Make the best decision that you can. And Africa House, as an independent contractor, you are waiving any liability. You're holding Africa House Sacramento harmless in your activities. And in always what you do, please use utmost discretion and do no harm as a judgment that you really have to make. Do no harm in your decisions, in your activities, and the processes that you undertake in carrying out your very important and responsible and critical aspect of this work, the project, as a community health educator, as a vaccine influencer, as an outreach worker, as the street team. Later on, we can strategize in terms of how we can work as a team, collaboratively and effectively, as well as efficiently, in a way. Okay, so let me stop there for now. See if anybody has any questions. Any questions? Okay. Is this a very quiet group or what? Okay. Let me talk about let me stop the screen share here and talk about the terms of service, and then come back to you with any questions you may have, and Dr. Deney will take the floor, or the cloud, as the case may be. All right. Okay. This is the independent contractor agreement that you'll be getting by October 1st, October 2nd, rather. You will be getting this and signing this and receiving your first, payment. I'm not going to go through all of it now, but give you a good sense of what is here and expect, and probably maybe get it across to you so you can take a closer look at it before October 2nd. This is basically the information in the application you completed. This is independent contractor agreement between you and the client here, meaning Africa House Sacramento. I'm the project director, as I mentioned earlier on, so probably you know. We have a team working on this project. It is, approximately 50 people, at least, are working different aspects of this project, and including the what I think Raven yesterday called the street team or outreach team, or in this case, really community health educators team. So, okay. The payment is $1,600. There was some question the other time about possible bonus. I'll think about that and get back to you. But this is what the payment is. Bonus meaning people who go beyond the call of duty, if you may, what that may look like. The scheduled payment will be on October 2nd. That means when this training will conclude, and then you sign upon completion of the training and signing of this agreement. $160, and then the balance of the payment will be made in November, December, January, February, and then final payment in March. Like I said before, please feel free if you have any questions or concerns about any aspect of this, please do let me know. Like I said, this is a collaborative endeavor. So we're not going to give you a particular date and time to do your work. From October 2nd, once after that training is done, is basically up to you. What we would expect you to do is to report weekly in terms of your activities, and then at the end of the month, you will submit your invoice along with any relevant data or data that you've collected. You are responsible. We will give you the information you need, the materials, the door hangers, which would have key information as part of it, which we'll talk about next week. There will be some promotional materials, t-shirts, masks, and gift certificates, limited number that we'll give you, that you will use and give out as you deem fit, and be able to report accordingly. Okay. Anything else is basically in terms of expenses, you'll be responsible, for that as an independent contractor. Okay. At the end of the pay period or year, our bookkeeper will be getting some paperwork from him at some point about the paperwork that will be needed for 1099 as a non-employee compensation form or as an independent contractor. In other words, we are not withholding any deductions or taxes. You'll get there's a 1099 or so at the end of the year for any payments for you to report in your taxes. Okay. So again, we are not requiring any licenses or business certificates. Again, whatever you do, make sure you do that not only in terms of safety, as I've mentioned, to the best of your knowledge and ability in the federal, state, and local laws. Especially this particular endeavor, there is nothing that requires any licenses or permits or certificates for you to do your work. But when you do your work, be mindful of the COVID-19 protocols, masking, social distancing, sanitization, and so on and so forth. If you're vaccinated, dealing with people or in an environment where people are vaccinated or unvaccinated, and so on and so forth. I talked about the taxes before. You here, if you have anybody that's working with you, that will be your responsibility in terms of the terms and conditions of that. We don't need to know that, it's up to you. Including any unemployment compensations, that may be workers' compensation, and this is again important in terms of liability. As an independent contractor, you are on your own and you are indemnifying Africa House from any liability. If for some reason at any point you would like to terminate this, it can happen if there's no funding, but you don't have to worry about the funding. We're already funded for this project, so it's our commitment up to the end of this grant in February. Should you, however, wish to terminate this at any point, give us at least 14-day notice in writing. That'll be important. This is the agreement and the only agreement. And again, incorporating what I talked about before in terms of the expectations, your responsibility, and your role. Incorporated in here. Confidentiality is important. Any conflict resolution will be under the state of California, including mediation and arbitration first before any courts. Okay. Confidentiality again is very important. You will come in contact with people, may share information with you. You protect that information, as well as any Africa House information that you receive as a result of your work under this grant. Okay. We return for Africa House any materials that we have given you, but you have yours in terms of any work that we have developed will be ours for Africa House Sacramento. Any ones that you have developed yourself on your own is yours. Okay. This is the only work that we have. If I say we are partners, not necessarily in a limited liability company type of partnership, but much more in the spirit of collaboration as we do this. So, so I think the rest are basically legal mumbo jumbo, if you may. But I will make sure you get this before October 2nd in a final form, so you take a look at it and make sure that we are on the same page. Okay. So let me, if anybody has any questions about what I've just gone through, if you want me to scroll to any part of it, let me know. Are we all good?
There's a question in the chat.
Okay, go ahead. I'm sorry, I'm not seeing the question. Can you read the question for me?
The question says whether the 1,600 is for the duration of the training, or is it per month?
The 1,600 is the duration of the grant as stated in the application. That's here, right? Yeah. So upon signing of the agreement, October 2nd, you get $160, and then the rest of it, which will be $1,500, we will pay over a period of time. Like I said before, there is a question that or a suggestion that was made about the bonus. I would, I can welcome discussion around that, and then maybe before the end of the program, before the end of the training, I can address that. And we looked around in terms of what others are doing out there in the community related to this project, and actually ours is a little bit more. I'm not suggesting that we want to make sure that we give you some compensation for your time, but I'm definitely sure, like anybody working on this project is putting in, doing it much more out of the passion and the need in the community, much more than profit. So, okay. And that will be a certificate that will be provided to you upon completion of the training that will be signed by me and Dr. Adeniyi. Okay. Any other questions? No? Okay.
I have a question.
Go ahead. Yeah, go ahead, please.
So When we go to these home visits or, knocking on doors, do we have a script that we generally follow, or is just that do we have to come up with how to convey this information?
That's a good question. Yes, there will be, that's part of one of the things Raven will be talking about on the 29th,
Okay.
what that would look like, to give you some foundation.
Okay.
But that's where the being creative, being innovative, yeah, will come in. What else do you add? Do you add to it, right? Yeah.
Okay, yeah.
I can answer it a little too as well.
Yeah, please go
you
ahead.
you guys will have it's not going to be pre-scripted, but you'll have what's called an elevator pitch. So it'll be about 20 seconds and you'll tell your story. Now I don't want you to follow it by the letter because then it sounds robotic. But I will teach you guys how to tell a story within 20 seconds that's effective and makes the person emote, and so they begin to trust you. So our biggest thing that we're fighting with this particular, with this campaign, we're fighting misinformation.
Yeah.
4 out of 10 Americans get their information from social media, and the majority of it is misinformation. So I'll give you a short little, it'll be about 20 seconds, and you'll be able to say everything that you need. You'll also put in your own personality and your own personal experiences. So it'll be effective and they'll continue to talk to you, not shut the door in your face.
Okay. Thank you.
Any other ones? Any other questions?
I have a question.
Go ahead.
Okay. Is it possible to get something that we can put out on social media, whatever platforms we have, because people tend to go there to have information. So if we can get something that we can stand by, that we can keep putting on our pages, that people can read and can spread it from there, generally, not just because it's for Africa House, in a way.
For this project in particular?
Yes.
I want to say generally yes, but Raven, can you respond to that now, or you want to take that on the advisement and
come back? No, I can talk to that, speak to that as now too.
Yeah,
we are creating a social media campaign. So when you all start going out there after the 29th, you'll have a lot of information that you'll be able to refer back to. So it'll be the Facebook page, it will be a Instagram page, and it may be a Twitter page, but the Twitter page will be just strictly informational, not really engaging with the people who patronize Twitter. So you will have all of those resources available to you once you start to go out there and speak to them. So they'll already have a general idea of who you are. So you won't go into it cold.
Okay. I hope that addressed your question.
Yeah, it is. Yeah.
Okay. All right. Okay.
Okay. And if you have any follow-up questions too, I'm going to put my information in the chat box, and you guys can definitely email me as far as it relates to promotional advertising.
Okay. Again, the door hanger that you will be getting is under construction now. Would have on one side of it some useful information in terms of where to, based on where people live online, to get the vaccine or testing, or call Africa House or email Africa House if they want to talk to any of our medical team members. And if they need help with transportation. And also part of your work would be to help those that may need help with making appointments, or saying, can you tell me where I can get the vaccine? You already have that information. You can pass that information, whatever you can do to ease the ability to get the vaccine. It doesn't mean that you're going to transport them to where they're going to get the vaccine, but you can point them to where they can get transportation, so that door hanger has that information. And I think Raven also is kind of working on a QR code that would also be kind of social media friendly, accessible as well. So yeah, so definitely Amaka's question in terms of part of your outreach, part of your work would be, as I mentioned, online, whether it's your personal Facebook, whatever means that you have. And even though, yes, our target is the greater Sacramento area, that's what our grant is. But of course, you find out that in the social media world, people from all over the world can. Yeah, we would like to know that, but not to take away from the Sacramento that we have reporting on those that we're able to reach to share the information, and hopefully how many were able to get the vaccine in our target population, the greater Sacramento area. So, okay. All right. Any other questions? Otherwise, we'll have Dr. Denny, who has been really great as our medical specialist, and introduced himself earlier on, so I don't need to reintroduce him again. We have been on this journey with him even before the grant, since February this year. Some of the probably darkest moments and fears and concerns as to about the COVID-19, and now we have the vaccine. How we can get our people to take advantage of it. So, I appreciate his great work. So, Dr. Denny, please, it's over to you to take it up from here. Thank you.
So I'm going to send a couple things in the chat in terms of, I think, helpful, reputable websites that provide some frequently asked questions. We'll go over a little bit of that, but I also wanted to make sure that we go over some of the other misconceptions that people may have, and to make sure that we go over some of the questions that you may have, because one of the things that I've realized in doing this for a while, we still, even those of us that have gotten the vaccine or advocating for the vaccine, we still have questions, and we will get presented with stuff and not necessarily know where to get the appropriate answer or how to answer it correctly. So I want to make sure that we feel comfortable with that as we continue to advocate for our communities to be vaccinated. So I'm going to I just realized that I was on mute the whole time, so you didn't hear anything I just said.
Oh no, we heard you up until the last.
Yeah, we heard you.
Oh,
yeah. No, you're on mute now.
You can hear me now.
Yeah, we heard you, except the crossword. We didn't hear the crossword. So,
so sorry about that. So in any event, so I put in the chat a couple FAQs from the CDC that I think are really helpful because it does help address a lot of the misconceptions that many of us have had. And then the other part that I always want to be mindful of is that when we're going out to the community, remember that they're likely in a position that some of us were in a little while ago. I know for myself, early in the process, a year ago, if you had told me that I was going to be getting a COVID-19 vaccine at the end of 2020, because it's been almost a year since I've gotten mine, I don't think I would have been able to say yes. So we have to remember that everyone's at a different stage of change. So we need to be mindful of that. And while it can be frustrating when we've already made that onto that point of the state of change, we have to recognize that other people are still on that process. So I'm not sure if people are familiar with the different states of change in terms of being pre-contemplative, contemplative, in action, in treatment, or in maintenance. Many of the people that we're trying to work with are probably in the pre-contemplative, maybe getting ready for action, but later in the game, they tend to they might be a little more stuck in their ways. So we have to make sure that we're not necessarily going to change people's minds overnight, but at least provide them with information that's in a caring manner that looks out for their best interests. So with that said, I'm going to share my screen in a second. Once I can get to my PowerPoint. We'll walk through a couple things, but please, I'm hoping that people will stop me, ask questions, because the goal isn't for me to just talk the whole time. It's to make sure that we feel comfortable with the answers, so that if there's something that you see on here that you're not really sure how you would explain to someone else, or how you would get out of answering the question if you didn't feel completely comfortable, we want to make sure that you have that information available to you. So with that said, so the vaccine FAQs, addressing some of the myths, and then hopefully a Q&A. I recognize that we will take a break before the main talk that will start at 11:30. So Dr. Nwaze, how much time do I have? About like 20 minutes or so?
Yes, yeah, and we would like to have some more time on the program for some other group work. So if you can,
I'll
thank
go
you.
quickly.
before that, thank you.
So with that said, the FAQ is going to be a huge component of what you use, but just quickly going through. So this is, once again, I always try to bring it back to what we're doing in California and Sacramento County. I do recognize that there's some people that are representing other counties, but I think it's important to be mindful of trying to center it to where you are. So once again, the main reason why we're still talking about this is that California, 90% of California is still at a greater than at either substantial or high transmission rates, which means that at least 10 per 100 or 50 per 100 are being infected with COVID-19. So it's still very much a big issue as to what we're dealing with. And Sacramento County is definitely still in the high category at this point. These are specifically looking at the case rates from a couple weeks ago in terms of how many cases we were seeing and how many deaths. While some people talk about the cases, people that tend to be a little more skeptical, they say it doesn't really matter how many cases if it doesn't mean that people are dying or being hospitalized, which I can appreciate. But if you look at the right side, we can see that we're still seeing a number of deaths. On the right side of the graph, you see that from December to March was the huge peak where we're seeing a significant number of deaths. And while we haven't seen the huge peak again in the July, August, September range, it's still an increase from where we were in May and June. And then similarly, looking at the hospitalizations and the ICU beds. When we look at it specifically for Sacramento County, this is more information that some of you may have already seen before. This is something that's available on the dashboard with Sacramento County, and Dr. Gasserier may make reference to some of this information. But once again, you see just the number of cases went up dramatically in the July, August timeframe. Thankfully, as we go further into September, the number of cases is starting to slow down, but this is just based off of the most recent variant that we have, not the ones that are upcoming. And this is the area that I think helps grounds us into why we're doing this work in terms of the number of cases per race or ethnicity. And you can see those that represent the Black African diaspora are at a significantly higher case rate than some of the other populations that live in the Sacramento area. So, and we'll see a little later that our vaccination rate definitely is lower than others. So while we are getting infected more, we're getting vaccinated less, which is really problematic, and it can cause generational issues as we lose some of our key figures in our families. Similarly, as I mentioned, the case the rate here. These were some older numbers in terms of how the positivity rate, how many cases we were having, how many tests we were doing. The more tests, the more likely you're going to see that people turn positive. But we can see that the positivity rate was around 7% at that time when it was averaging a little less than 6%. And this is the area that tends to be the focus of for people like myself and other physicians. How many people are having to be hospitalized? How many people are having to be in the ICU? Not just for them, but how does it impact the care of everyone else? And the numbers got as high as 420s and 120 ICU cases, but thankfully now those numbers seem to be trending down, but we'll see if that continues. And then unfortunately, as we see here, the vaccination rate hasn't really caught up. So while we've had many more people testing positive, we haven't had many more people getting vaccinated. And that's why the work that you're going to be doing is so important to what we do going forward. And here is where we talk about the vaccination rate. So while we talked about vaccine rate, the case rate being the highest, around more than 7,500 per 100,000 in Black and African diaspora, our vaccination rate as of 2 weeks ago was 39%. So these are some of the questions that you may end up getting from people, just in terms of we often get a lot of information from the media about the Delta variant, and as others have said, many people get their information from social media. So these are some things that I want to make sure that we feel comfortable addressing as to why the Delta variant is any different from the other variants that we've dealt with. Why did we end up having to, in some places, feel as though we're going into lockdown when we didn't go into lockdown a couple months ago? So the key thing that I want you to take away from this slide is that the Delta variant is as contagious as the chickenpox. And that's why we're taking it a lot more seriously. You see, as you go to the right of the graph, it spreads faster. So measles is one of those things that when there's a measles outbreak, a lot of people are going to get measles. And then as you go up, it's more deadly. So that's where you see things like SARS and MERS, which are other kinds of coronaviruses that came before COVID-19, that when people get them, the outcomes tend to be much worse. And with the Delta variant, you can see that it might not be as deadly as MERS or SARS, but it will be more infectious than polio, smallpox, the common cold, and the flu. So this is why we really need to continue to pay attention to it, because early in the process with there's been Alpha, which was the first located out of London. For every one person that got it, 2 to 3 people would be infected. But with the Delta variant, we're seeing that for every one person that gets it, 4 to 7 people can get infected. So it can spread much more rapidly than what we had previously seen. I've already talked about that a little bit, so I won't bore you with that information. Moving on to the next slide if I can. And then what are the long-term effects of COVID-19? So one of the common things that we hear is that, oh, it's just like having a cold. Most people survive and do fine. And while that's true, 90-something% of people who end up contracting COVID-19 will survive. That still has left in the United States alone more than 650,000 people who have died. But then in addition to that, there are a number of people that have had long-term side effects associated with COVID-19 where they haven't gone back to their baseline. And that's the other group of people that we're trying to look out for. So with that, these are some of the things that you may see and you may hear people ask about. So if they say, oh, the chances of me dying are low, you could affirm that and saying, yeah, that's probably true. There are cases in which many people do well, but these are some of the things that you may note if you were to get COVID-19. Fevers and chills tends to be a thing that we are still seeing a lot. A dry cough, shortness of breath. The one that people, if you have this symptom, chances are you have COVID, even if you have no other symptoms. The loss of taste and smell. If you have that, like, you definitely need to be checked out. But you also see other things that you may not have thought about for respiratory infection, like diarrhea, nausea, or vomiting. So these are things that we have to be mindful of. And then the COVID long haulers. So this is for people who end up having symptoms that last longer than 4 to 6 weeks. And we're starting to see that this is happening more and more as we get further along in the COVID-19 pandemic, where people have ongoing fatigue, like they just can't recover. They have ongoing body aches and joint pains, ongoing shortness of breath, where they had to use supplemental oxygen when they didn't have any issues with the oxygenation in the past. And some people have prevailing loss of taste and smell. And then the last one that I mentioned is the brain fog. And that's where you just don't feel as though you're able to compute or do things the way that you're doing it before. It's like a haze. It takes longer for you to comprehend or calculate stuff. And that's something that I've seen several times in the last couple of weeks. So why getting vaccinated? We already know that all of you are going to be advocates for this, but to give clear, concise answers to that, and I know Raven will be providing some that elevator pitch too, but ultimately the two things that we tend to be mindful of is protecting yourself and protecting others. So in terms of protecting yourself, it reduces the risk of infection for you, whether that be asymptomatic, meaning that you have no symptoms whatsoever and you just had to get tested for like screening or you're going somewhere, or if you're symptomatic, meaning that you presented with any one of the other symptoms that we talked about, whether that be fever, chills, shortness of breath, fatigue, diarrhea, loss of taste or smell. And then the other part, which is extremely important, is the preventing hospitalization and death, because once you end up having to be in the hospital, you end up having to be on quarantine a lot longer. It tends to be 3 weeks instead of the 10 to 14 days. You also, once you're in the hospital, you're at risk of getting other infections. because you're in a hospital setting. And then the risk of death. For more than 99% of those who have died from COVID-19 since the vaccines have been out have been those that are unvaccinated, which is a startling number. And the CDC recently came out and talked about those who are unvaccinated are 11 times more likely to die than someone who's vaccinated, regardless of what the vaccinated person's risks are. And then the other part is to protect others. So vaccines reduce the transmission of disease because you're less likely to be infectious. You're less likely to have as much virus in your system, even if you had, even if you contracted COVID-19, and you're much more likely to quickly recover from the disease than for those who are unvaccinated. And if there's anything that I want you to take out of this slide deck, is this: protect yourself and protect others. If you could say these things, I think you'll be able to make a big difference for people, and then that you'll be able to continue the conversation thereafter. But ultimately, if we can make a connection on this, and if you have a personal story that brings this to light, that's even more important, because people, the emotional connection to what you say is going to probably cause them to bring it's much more likely to cause them to bring about change than for you to just state facts. Because the facts have been out for a long time, but that's not necessarily the thing that's going to change people's minds at this point. And then another area that we tend to talk a lot about, and once again, the media talks a lot about this too, is just what about breakthrough cases? We obviously, and maybe it's not as obvious, whenever there's a vaccine that comes out, no vaccine is 100% successful. The flu vaccine is around 50 to 60%. So half the people who get the flu vaccine still may get the flu. Once again, you tend not to have nearly as bad symptoms, but you still can contract it. With the COVID-19 vaccines, like depending on if you get the messenger RNA vaccines or if you get the Johnson & Johnson vaccine, which is an adenovirus vaccine, it's more than 90% protective. But that still means that 5 to 10% of people who got the vaccine may still end up with COVID-19. So with that said, one of the things that I think is really visually important is being able to show people the difference. So this is information from like a month ago in San Diego, but those who are unvaccinated, how many hospital beds did they take up versus those who are vaccinated? And here you see it's like 14 to 1. I know that other hospital systems are starting to share this information more often. I know UC Davis has started to share it, but other hospital systems are letting us know those who are hospitalized, those who are in the ICU, what is their vaccination status, partly to help emphasize the importance of being vaccinated. And then how do the vaccines compare? So there are 3 vaccines that we have in the United States, and some people may ask you, and this is where I think it may be helpful for you to just have them talk with their healthcare provider in terms of which vaccine would make the most sense. We've often said any vaccine is going to be beneficial, and that's still very true. The 2 vaccines that we often hear most about are the 2 messenger RNA vaccines, the Pfizer vaccine, which is now Comirnaty, and the Moderna vaccine. Both of them require 2 doses. The Pfizer vaccine requires a dose at 0 days and a dose 3 weeks later, and the Moderna vaccine requires a dose at 0 days and 4 weeks later. But you can see here, and by no means am I expecting everyone to understand everything on this graph, but what we're seeing here is the blue dots are the Alpha variant, which is the one that we saw out of London, and then the red triangles are the Delta variant, which were initially seen out of India, but even in the United States at this point, 95+% of all new cases of COVID-19 are associated with the Delta variant. We see that it has a great job in protecting against infection for both the Alpha and Delta variant in terms of Moderna and Pfizer. We see that it also protects against hospitalization. The one area that's people have started to hang on to is what we see in Israel. But even here, when we look at the Alpha variant, it did a great job in terms of protecting against infection, symptomatic infection, and severe illness. And while it does show that there are people who get infected and have symptoms, there are very few people that end up with severe illness. And even those that have gotten infected and had symptoms, they tended to be an older population. And now they're starting to get booster vaccines to help reduce that risk. And then there are going to be some people that say, oh, I shouldn't get the vaccine. And there are some people that shouldn't, but that's a very, very small, very small group of people. Yeah. But what about those that are breastfeeding and in pregnancy? Completely safe. The American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine, the two largest organizations that work around maternal fetal health, both recommend vaccines for those who are pregnant. The risk of COVID-19 in someone who is pregnant is far higher than the risk of any complications associated with the vaccines. There have been more and more reports of those young, because generally speaking, in terms of pregnancy, the patient population tends to be in the 18 to the 45 range, with not as many health conditions. We are noticing that more women who are pregnant who have gotten COVID-19 unvaccinated are having really poor outcomes. There's been a significant increase in the number of miscarriages associated with COVID-19 in that population. So it's something to be very, very mindful of. And then there's the other group for those that are hoping to become pregnant. And there's been a lot of miscommunication around infertility. Around the vaccines. There's been no data to suggest or support infertility issues with the COVID vaccines. And there's been tens of thousands of women who've gotten pregnant while they've either gotten the vaccination or in the series of getting the vaccine. So that's another thing. And then how safe are the vaccines? So once again, this is a couple weeks old, but 172 million plus are fully vaccinated, and there's already been around 377 million doses given in the United States. Considering that we have less than 377 million people, that's a lot of doses. So given that, it's not a small experiment. Generally speaking, when we do trials for vaccines and other things, we see 5,000 to 10,000 people. With these trials, we had 30,000 to 60,000 people. And now we've had millions and millions of people that have received the vaccines in the United States, and then more than 5 billion people that have received vaccines, or 5 billion doses that have been given around the world. So, additional information, but I want to make sure that we leave time for the other stuff that's on the menu in terms of specific safety stuff, because this is a legitimate concern. I know most recently Nicki Minaj had Twitter on fire with her claims around vaccines, but this is actually the safety data around the vaccines. The messenger RNA vaccines are very, very safe. While there are some people that end up having poor outcomes, it's usually in people who have already had the risk and they do well when they're in medical care. And that's part of the reason why we have people wait 15 to 30 minutes after getting the vaccine to ensure that they do well after the vaccine. There have been cases of concern around vaccination in young men in terms of potential infection or inflammation of the heart. But what we've learned is that with COVID-19, and I apologize that it says COVID-10, with COVID-19, they're 6 times more likely to have a poor outcome from COVID-19 itself than they are from the vaccine. So it's highly unlikely that the vaccine is going to cause them any issue. But one caveat that I do like to point out is just in terms of the Johnson & Johnson vaccine. It is a vaccine that can be very helpful. It's a 1 dose currently, and we are waiting to hear about whether people are going to be getting boosters. But I can only speak for myself. It generally is a vaccine that I tend to shy away from for women that are between the ages of 18 and 49, just because there is a risk of a pretty rare but severe kind of blood clot. So if we are to have people vaccinate, I would probably err on the side of the Pfizer or Moderna vaccine in that population, but otherwise it is a very good vaccine. And I don't think we'll talk about this during this one. We may bring this up at the next session, but we'll come back to that. And then we'll talk about the boosters. And I believe that Dr. Kasiri will probably bring up the boosters in our later session this morning. But this is the last one that I'd probably bring up, is just make a difference of why do vaccines make a difference? There are many people that feel as though I'd prefer to stay home anyway. I wear a mask everywhere anyway. Why should I get the vaccine? And it's ultimately to show that there are multiple different layers that we have to help protect us. No one layer is perfect. No one layer is going to provide all the protection, but we have the masking, we have avoiding touching the face, we have the ventilation systems, we have the quarantines and isolations, and then we have the vaccines to help us get through this pandemic. And it's already been almost 2 years and we're not quite through it yet. So the vaccines are still a very much important part of the picture. With that said, I'll probably stop because I think I ran a little longer than I would have preferred, and wanted to see if there are any specific questions or concerns that you may have that you want to be able to provide information to your community or to the people around
you. Thank you, Dr. Adeni. I'm glad you corrected that. It's still COVID-19, not COVID-10. I was like, are we getting another one?
Not yet.
Let's work hard to stop another COVID variant. Thank you. All right. Any questions for Dr. Adeni? I think
I have a question.
We can make the slides. Go ahead.
So I have this colleague in the office that has bluntly refused to get the vaccine. And when we had the OSHA meeting in the office, she said that she was going to use the religion as her excuse. And she's Catholic. So I told her that, oh, even the Pope said, go get the vaccine. So what is your new excuse? So on Friday, we were kind of discussing this, and she was so adamant about it that even her kids don't get the flu vaccine. I said, why? She's kind of, okay, they're going to get it anyway, so why do I have to get the vaccine? So what would you say to somebody like that? How do you convince the person? What do you say to kind of get in their head, in their space?
So great question. So one of the things that I failed to mention a little earlier is trying to figure out where people, like, in addition to like stages of change, like I tend to break people into separate categories in my mind, just based off of simple conversations like that. Like, are they the vaccine enthusiasts? Like, they're going to be the first adopters, going to get vaccinated very quickly. Those that will be early adopters, those that tend to be a little more hesitant, like they want to get a little bit more information. Those that are resistant, that like they get vaccines, but it's not like they're going to be jumping to get every vaccine. And then those that are considered the anti-vaxxers, meaning that they likely would not be getting any vaccine of any sort. It sounds like this individual is likely teetering between the vaccine resistant and vaccine like anti-vax. So it's hard in that situation. And that's why we end up having the mandates for some people like that. Because if they're unwilling to necessarily protect themselves, or the people around them, sometimes it's a requirement of their job to keep their job. Otherwise, they have to lose that ability in their job. So
she's ready to lose the job because my office told her that by September 30th, it's either you're vaccinated or you leave the job, and she's ready to leave the job.
And that's the thing. So people still have free will, which I completely appreciate and understand, but they're not free of the consequences of those choices. And that's ultimately what ends up happening. So for that person, I'm not necessarily going to spend a whole lot of time trying to convince them, other than providing them with the information and potentially asking them, so what would cause you to get the vaccine? Sometimes if you're able to flip it on that end, then maybe they can provide you what things is hanging them up. But for those that are truly anti-vaxxers, there's going to be nothing. Nothing's going to cause me to change. For those that are hesitant, they'll provide you some things. They'll be like, I'm still a little concerned about how quickly it seemed as though this came out. I didn't realize, like, I have certain health conditions that I'm concerned about. How does this play out? Those people are much more willing, if they're given the information, to make a decision to benefit themselves. The ones that say there's nothing that's going to change me, I don't spend as much time with them. I probably can convince 3 or 4 other people in that same time frame.
Okay.
Great question, great response as well. Yeah, we can always provide information, and hopefully they will get the epiphany at some point to make that decision. So, but yeah, I think turning around, what would it take to get you to change your mind?
Yeah, and one of the things that I felt to also mention on here was just in terms of, for those that have had COVID before, where I'm dealing with it at my current job, and we've been, as healthcare providers, we're mandated to get vaccinated in this regard. And we have a couple people, not healthcare providers, but people that work within our organization that are adamant about not getting it. And one of the things that they've talked about is the fact that they got COVID-19 and got over it. What is important to note for them is that there are at least 30% of people, 30 to 40% of people who get COVID-19 don't develop the antibodies to protect them against it again. So getting COVID-19 the first time doesn't mean that you can't get it the second time. So in those, I always say, yes, you definitely would benefit from getting the vaccine, because the thing is, if you get it the second time, it might be a much more dangerous variant. The first one didn't take you out, but the second one may. So you don't want to take that chance. So that's oftentimes what I try to highlight with those that say, like, I've already survived it once. It might have been tough on me, but I got through it. I'm like, you might not be able to, unfortunately, you might not be able to get through it the second time.
Any other questions?
Okay, so this will be to Dr. Adenyi. I think of recent times, I think there's been an increase in clinicians or doctors who are giving patients exemptions in terms of religion, and this has gathered a lot of following. And how do you think this is going to pan out? Because people are actually using that as a scapegoat to not get vaccinated.
Yeah, so there are 2 parts to that. So there's the medical exemptions and then the religious exemptions. In terms of the medical exemptions that people are giving, they're going to be suffering, those clinicians are going to be suffering the consequences of their medical societies. So as a physician in California, I received a notice about a month ago saying that if I were to be giving out medical exemptions for the COVID-19 vaccine without any cause, I would be subject to discipline. So people are gonna have to deal with that. So oftentimes what I know certain organizations, including my organization, is, while we can't specify what the specific condition is that warrants the exemption, we do have a disclaimer that says that this medical exemption is in compliance with the CDC recommendations as to what is considered a contraindication. So currently, the only contraindications for the COVID-19 vaccine are if you had an adverse reaction to a previous COVID-19 vaccine, if you have allergies to the ingredients of the COVID-19 vaccines, and all 3 vaccines don't have the same ingredients. So you would have to have lots of allergies. And then there's a somewhat soft exemption for those who are pregnant. Well, it's ACOG and SMFM have both come out in support of the vaccine for pregnant women. That is still something that's being given as a soft. I can't remember the exact word, but it's a medical exemption is allowed for those individuals. So if it's outside of that, there's a really good chance that clinician is going to be disciplined by their medical society. And in terms of the religious exemptions, as previously mentioned, at least I can speak within Christianity, Judaism, and Islam, hasn't been any major sect that has come out in support of religious exemptions for the vaccine. And the other part with that is, if you were to say a religious exemption for a vaccine, but you got your flu vaccine or you got your hepatitis A or B vaccine, how did you end up switching at this point? So that's another one that we're keeping an eye on. I do know that there is a church out in Rockland that has been giving out religious exemptions. I think they've given out probably around 3,000. There's very good chance that they're not going to hold up in court, just because it's not a biblical rationale behind the religious around the vaccine exemption. But good question.
Thank you.
Okay, any other questions? And then we can get into the next topic of our agenda today, or the next agenda topic for today. All right. Well, of course, there may be other questions that could come up during the town hall, so please make note of that and ask. Dr. Denny also will be joining us for another presentation on the 29th program as well. So what I would like us to do, thank you very much, Dr. Denny, and great job, and we're very, very fortunate to have you on a team leading, help us with this project. So thank you very much.
Thank you for having me.
And thanks all of you for your good questions as well, participation. It looks like a few more people joined us after the program. You're welcome, Michael and E. Mukibi and Melody. You're welcome.
Thank you.
All right. So the next agenda item is to strategize, and I really want everybody on this team, community health educators, from what you've heard so far. At the beginning, I talked about your role and responsibility in terms of really being on the front line of this grant, in meeting people where they are, at home, places of work, on the street, and to do that safely, of course. Places of worship, no matter, private events, public events, both invited and not invited, but welcome. Those events. How to ease in and out of those to be able to spread the word and share the information and of course do that safely. And be able to report, accordingly. Again, our 39% of our people getting the vaccine is not acceptable. That's, in this area. That's Dr. Denny's data, current data, right? And that's, it has improved. Before the mandates, the various mandates, I think was like, about 25, 30%. It has, improved somewhat, but it's still not where it should be. It's not the herd immunity, so to say, that we're looking at, or the state or federal levels are aiming at, of 75, 80%. And I've always said that now that it is free, our people are not, most of our people or some of our people are not taking advantage of it. There will be a time that there will be a cost. In fact, I'm hearing, I don't know to what extent that is true or across the board, that some providers now charging some type of a deductible or some type of a fee in some establishments to get the vaccine. So I am concerned that there may be a time when there will be a cost to get the vaccine, and this will be another challenge, another hurdle, another barrier that would cause or worsen the health disparity of our people. So your work is very critical. I don't think we're going to reach everyone, but we can touch some people, and that's really, and we cannot be overwhelmed by, we cannot reach 60% or whatever, but we can reach 1%, right? And each one touch one, each one reach one, and we can say we have done our best, really. We have done our best. And that is really the reason why we are doing what we are doing. So your work is very, very critical, in this endeavor. So I'd like us to spend, about 10 minutes or so to kind of strategize from what you have heard so far. How are you feeling? What are your ideas in terms of how you think from your comfort level, make it happen? Dr. Denny in the chat said there will be an increase in deductibles for those who are not vaccinated. There may also be higher share of cost for hospitalization for unvaccinated. So really the cost is going to be quite higher and significant from all indications. So what can we? How do you see you doing your work? That's what the next agenda item is about. Open it up. Tendai, Onyelola, E. Mukibi, Michael, Erica, and of course, Melody, and Wamaka.
Can I ask a question?
I'm sorry? You're on mute.
Oh, I was just going to ask, just because it is a pretty quiet group, like I guess one of my questions is, what do you foresee being the most challenging part of the process? Like, where do you feel as though you may need? I did hear in terms of having the elevator pitch or having FAQ as being something like a tool that would be necessary, but where do you feel as though you may need some support?
For me, I think maybe like when people, like, even though you do your elevator pitch and try to be as polite and as respectful as possible, people start to get hostile towards you and they just want to like look for a fight. How do you de-escalate that? That's what I could see myself a little bit struggling with.
Yeah, and we can talk about that. That's going to be part of the agenda on the 29th. That's a good question. And of course, when we say safety, right? When you see the most the first thing you should do is remove yourself from such environment. I mean, really, that's the first thing that one should do. But we can talk a little bit more about the point of entry and also exit, on the 29th. So.
Yeah. And acknowledging their passion. I often have patients that talk like that in clinic, and I'm like, I can appreciate you're very passionate about this, and I recognize that this might not be what you want to talk about right now. Just know that I'm looking up. I'm trying to look out for your best interest, but we can move on from that conversation. Like, yeah, I don't want to get into a fist fight over a vaccine.
Exactly. Thank you.
Mm-hmm.
Okay, I have a question.
Go ahead.
Is there a possibility of having something more like the October 2nd program, where you can have more vaccines on site to give to people? But I'm thinking of in a situation where if we're going to work independently or in teams, I think better like 2 people, maybe in a particular zip code. It's easier for people to work in that way than one person just walking around. So if you get 2 people in the zip, and let's say we go to a church leader to kind of get something set up for a particular Sunday or something, is there a way to get vaccines on site for those who might want to get it after we're done with the talk or whatever, if you can get to educate the church for like 5-10 minutes during the service? Is it possible? Something like that?
Yeah, the answer in terms of teamwork, yes, and we'll talk more about that on the 29th. By the way, this is what session 2 is going to look like. This is a draft, but essentially kind of gives you a sense of that. And that would be kind of the teamwork, whether 2 or 3 people looking at the zip codes. Really, that's what I was saying. Kind of think about that, because the support is very, very important. So this is what the session number 2, 5:30 to 7 p.m. on the 29th will look like. And then on the last one, which is the field experience in the Oak Park area on October 2nd, where about 3 o'clock you will gather pretty much between 3:15 to 4:15 p.m. You go into the field really in teams of 2 to 3, and you will receive the appropriate instructions, and then you come back to the park at about 4 o'clock and report on your experience. And this is where then you receive your certificate of completion and related instructions, as well as your the first payment and your independent contract agreement. And this would kind of give us a sense in terms of where the additional support. Now that you received the training, you got into the field, then you can come back and tell us how that felt, and then we can use that to plan for any area of additional support or further training. And of course, during that event on October 2nd, unfortunately, there will not be vaccination at the site on that particular day. Because of some logistics with the city and liability. However, we are hoping after that to select a couple of clinics or pharmacists that run the vaccines to support them in a major way, especially those ones that are Black owned or in the target zip codes that we are working with. And that's, you'll be hearing more about how we're going to accomplish that, later. So, okay. So in other words, yeah, there will be teams. You will not be alone. That's one of the reasons I'm hoping maybe give some more thought to it in this session. Again, I would like to be as collaborative as possible. How you think this team can work effectively. Okay. I hope that answered your question, addressed your question.
Yeah, it does.
Okay, all right. Okay, any other questions? No questions, no more questions? If you were to think of one major strategy that you are thinking about, or you may have used, tried in the past that worked for you, what would that be in this type of work or related? What would you say that is?
Well, hi.
Yeah, hi.
I would say to educate the people on a lay level where they are. Use those words that are more familiar to that particular group that you're outreaching to, and just give it to them straight. Give it to them straight, the pros and the cons, and educate them about this thing, because a lot of what I'm finding is that a lot of people who are or claiming to be anti-vaxxers, or people who are not wanting to take the vaccine, it's mostly because they're uneducated about it. Especially the African American community. I'm seeing that more and more. You'll ask them, and they're just going by what their friend said. Oh, my friend says she's not taking it, I'm not taking it either, rather than just to get educated about this and make an educated decision. So that, I think that's where we come in, to educate them on a lay level, not a fancy PhD level. Shout out to the PhDs, but
thank you very much. Take that. I hear you. It makes sense.
Just a standard level, so that everybody can understand what we're up against and why there's a great need for you to take this vaccine.
Yeah, thank you. And the MPs, don't be jealous of the PhDs too. So you get a shout out as well. Thank you, Rella. You made a good point. And actually, one of the things that we really would want you to do as you reach out to these various communities, even if it's outside of your quote target zip code, but maybe a group within the area we are looking at, to speak to them in the language. The Ubuntu, One Love, Save Lives, Vaccinate thematic slogan will be translated in about 10 major languages that in addition to English language, of course. And the goal and would be part of what you will see on the door hanger or the flyer. And one of the things that we would like you to report back to us is if you're able to use other languages other than the English language, any of those languages outside of the English language, to share that information. This is also another way for us to report back to public health folks so that they can appreciate that there are other languages that may not be, that may be under their radar, right? That they can factor into the planning. So this is also very important. But yes, speaking to them in the Igbo language or in the Pidgin or the Creole or whatever, Hausa
or Spanish.
Yeah, exactly. Please, yes, and you can do that. It's important. Yeah.
Okay. Can I say something?
Yes.
Two
and
things.
Then we can take a quick break. Yes. Go ahead. Mm-hmm.
Yeah, in the resources we're going to get, the flyers or whatever is going to be, like what she said, in the language they understand. If you can use little examples of everyday lives that they would get. Like I have in my office, somebody asked me yesterday, oh, why do I see better with both eyes open than when I close one? And I'm kind of, okay, stand on 1 foot and then stand on 2 feet. Which one feels more comfortable? So he got it that, oh, it's better with 2 feet than 1 foot, and then it's better with 2 eyes than 1 eye. In a sense that they can get what you mean in as lowest as possible. And also trying to get across to the people. Like back home in Nigeria, what we did was to go to the community elders, go to the church leaders, and kind of get a program set up that we can actually talk to them. When the leaders are more poised or in a position to get that group together that you want to talk to, than when you go to them separately. They tend to listen to their leaders more. Oh, come together here, let's have a talk on this. If that is feasible, then it will be a good way of reaching more people at the same time than spending 3 hours walking around to different homes. Does that make sense?
Yes, and a part of actually part of it, we have put 3 hours or 3 to 5 hours a week could be trying to make those contacts, and where we have a task force that represents different cultural groups and faith organizations. If it's a matter of reaching out to any of them directly or indirectly to help as brokers into any of the communities, just let us know. But definitely part of your time may be spending trying to explore who will be the right person to talk to and how can I make that point of entry to be able to make the connection. It is important to do that. Okay, let's take a couple of minutes break and then we'll start in about 3 minutes with the town hall. Mr. Ochingwa, please take note of those participating in the community health education training for the record, and we'll figure out if we need to do follow-up with others later on. I know that our guest speaker is already here, has been patiently waiting for about 10 minutes. Dr. Kasira, great to have you join us. And Dr. Hunt. Dr. Denny, I don't know if you've met Dr. Hunt. We know we've kind of talked about possibility of connecting with her later on, given her work that may be relevant to this project. So you're welcome as well. Okay, and so let's take a quick 2-minute break and then we'll come back and we'll start and then with the town hall, please. Thank you. Okay. Good morning, everyone, and welcome back, or welcome to Town Hall number 4 and our continuing education series on the COVID-19 grant project to educate, outreach, and support our community of people of African descent in the greater Sacramento area. We started at 10 o'clock, the first part with the training of community health educators. And that training will continue with the town hall number 4 until 12:30 today. We have already started with a prayer. And so as my Nigerian folks would say, we'll stand on existing protocol of the prayer. We know that we all in this together, and then we'll have a closing prayer as well. I cannot do that. We are very pleased and grateful for our guest speaker today, Dr. Olivia Kasire, who has been on this journey with us since last year. Probably some of the earliest and darkest and uncertain, anxious moment, and at the beginning of the pandemic, in educating our communities, and has remained a stalwart leader in guiding us through this difficult period as the Sacramento County Public Health Officer. And I know when she says, those health orders that you think about, I sign them with nothing but our safety and health in mind, nothing but that, despite the challenges. So we're very grateful for her leadership, her support, and really passion for public health, and really is an epitome of service in these endeavors. We're very grateful. Thanks each of you for joining us. So our medical specialist, Dr. Adeneye, I will let you pick it up from here. Again, welcome on behalf of Africa House Sacramento and the Grant Implementation Task Force team, and with acknowledgement to California State Government Operations Agency for funding this project. Of course, continuous support from the Sacramento County Public Health. To each and every one of you here being part of this endeavor, you are welcome, and I thank you very, very much. So for the next hour or so, we'll be on the town hall number 4, and Dr. Adeneye will start off, and then we'll bring our guest speaker. Dr. Adeneye.
So I will only speak briefly, just an introduction. So once again, our goal is to continue to empower, educate, encourage our community. And I'm very thankful in having Dr. Kasire here to provide us a new update on things that are happening now and what's to come within Sacramento County in regards to the COVID-19 vaccine and the pandemic itself. So with that said, the goal is for Dr. Kasire to present, and then we'll have some time for a Q&A to bring up any other questions that come up as a result of the presentation or other things that may have come up as a result of what we had talked about earlier in the day. So with that said, I'm going to step out of the way and let Dr. Kasiriye do her thing.
Good morning, everyone. So are you going to pull the slides up?
Yes, we can pull them up. Let me see if I can pull them up.
And while the slides are coming up, I just want to thank you all for being here and for the opportunity to share. Real quick about myself, I am originally from Uganda. I've been in the US for about 30 years. My medical education was in Uganda, but I also have a master's in epidemiology from UC Davis, and I'm board certified in public health and preventive medicine. I have been health officer originally for El Dorado County for 3 years, and then starting in 2012, health officer for Sacramento County. So great, thank you. So I'm going to just have a brief, a few comments to provide. And of course, the topic is about vaccinations. And the question a lot of people ask is, why should I get vaccinated? So I want to focus just on the numbers this time. Of course, there's a lot of information. I think I was told that the last town hall you discussed some of the myths and misinformation that's out there, and trying to differentiate the truth and the facts from what is being circulated on TikTok and Facebook. So next slide, please. And the reason I want to focus on the numbers is, of course, as being in public health, one of the areas of focus for us in public health is actually looking at numbers. And we are the ones who get, when a case of COVID is reported, it comes to public health. And so we provide this information. We do have a dashboard. I'm hoping that you all are aware of where that dashboard is. But I'm showing the numbers in a little different format this time because I wanted to highlight a few points that would explain why it's important for all of us to get vaccinated. So this first one is looking at the chart. The top one is the chart of the COVID cases by age, and it just shows for this year, starting in January. Of course, we know that we've been at this for almost 2 years now, starting in January of 2020. But we wanted just to show the numbers from January of 21, when we had the winter surge. And as you know, the numbers started going down as we started vaccinating. And in June, we were able to actually reopen in California, but then the Delta variant came along. And that's the surge that you see starting in late June and going on through September. So with the bars, you see that they're different colors, and the colors indicate the different age groups. And so you see that throughout the age group 18 to 49, which is the young adults, were the ones that had the highest number of cases. In the bottom left chart table, it gives you some of the numbers, and you see that for the total cases, the total number of cases, and then for the last 30 days. The median age has remained about the same. As I mentioned, young adults are usually mainly the ones that are getting COVID-19. But when you look at the bottom by age group, you see that for 0 to 17, overall, they constituted about 13.5% of cases.
Yeah, you don't want to get hit by that train. you just take it, because I'm not. I'll just turn around on you.
Please mute yourself. Oh my goodness.
Hi, Reverend, please mute. Thank you.
Oh, I'm sorry.
Sorry about that.
I thought she was commenting on what I was talking.
I know.
Anyway, so one of the things that we've noted lately, especially with schools opening, is as you can see here, in the last 30 days, the age group 0 to 17 now constitutes close to a quarter of the cases, 23.9. And so that again is a result of the schools opening and having schools in a congregate setting. So you have more opportunities for spread. But again, about 52% of the cases are in the age group 18 to 49. The right-hand table shows you the rate per 100,000. And as again, I noted that 20 to 29 and 30 to 39 age group have the highest case rates. Next slide, please. And this shows you by race ethnicity. The gray bar at the top shows you that's the white population. So what we have noticed is when you look by numbers, the white Caucasian have the highest number of cases, which is not surprising. They do constitute the largest percentage of individuals in Sacramento County. But one of the things to note, especially where it's much clearer when you look at the bottom left table, is that for the African Americans or Blacks, and actually on this one, it's improved a lot, but at one time, overall, African Americans or Blacks constitute about 13.1%. But in August, one of the things we noted is that actually that increased all the way up to over 20% of cases. It has dropped again now, so that is generally a good thing. And now we are seeing more of an increase in the white population. And in the table bottom right, you see the rate, and you do notice that the Native Hawaiian Pacific Islanders have had among the highest case rates when you look by race ethnicity. Next slide. And this, moving on to the deaths, and again, you will see that the yellow bar is those, and this is by age, yellow bar is those 65 plus. In previous surges, we had a lot of outbreaks, large outbreaks in the long-term care facilities, which includes the skilled nursing facilities and assisted living facilities. And so you see that the yellow bar is the longest when you look, especially at the winter surge. It is much smaller when you look at the most recent surge in August. And actually you see that the orange bar, which is 50 to 64, is much larger. If you look at the bottom left table, you notice that there has been an increase overall in 50 to 64, where now they constitute over 36% of the cases, of the deaths, as opposed to overall in previous surges where they constituted only 19%. So probably if you've been listening to the news, you'll notice that those are some of the points that we've tried to point out, that, and also when you look at the median age, 76, and that has dropped to 63 in the last 30 days. The good thing is that even though we have seen an increase in cases from 0 to 17, we still have a low death count in that age group. So that is good. But again, probably if you've been listening to the news, you will notice that for some of the states in the Midwest, they have had a large increase in pediatric cases, and they've talked about a lack of hospital beds for pediatric cases. On the right bottom table, you see again the death rate, and this is a point that people have brought up a lot, where they say, well, this is not a very serious disease because it's only 1% death rate. But of course, when you're looking at the number of people that are infected, even 1% is important. And another important thing is that you notice that when you look by age, it goes all the way from 1 per 100,000 for age 0 to 9 to sorry, I can't see the bottom part, but for 70 to 79, it's 452, and it's even higher for 80 plus, it's over 1,000. So that just shows you how serious this disease can be, especially for the older age group. Fortunate for us is when the vaccinations rolled out that there was a huge effort to get people vaccinated in the long-term care facilities. And so they are protected. We have not had large outbreaks during this most recent surge in those long-term care facilities, and that has helped to protect them. Next slide. So deaths by race ethnicity, again, when you're looking at the counts, still the highest number is in the white population. But when you look at the bottom left table, you notice that for the Blacks or African Americans, there has been an increase. And probably many of you have been touched by this. You either know somebody or you have a relative who has died of COVID-19 complications. And so as I told you before that earlier on in August, we had an increase in cases among African Americans, and now we're seeing an increase in the deaths because usually the deaths lag behind. So that is an area of concern for us. And also because I don't have it in this slide set, but when you look by race ethnicity for vaccination rates, African Americans have the lowest vaccination rates. At the bottom right, you see the rates by race ethnicity, and you see that, as we mentioned again, for the Native Hawaiian Pacific Islanders, they have the highest death rate. They did have a very large outbreak at the beginning of the of last year, and so we worked very closely with them, and we actually had special vaccination clinics for them to try and make sure that we got them vaccinated. But again, when you look overall, they have had the highest death rate. Next slide. So apart from the deaths, I think people sometimes forget that another problem that we have with COVID-19 is that even for people who are able to survive, many of them have complications such as pneumonia, and the pneumonia that they get usually is very severe, tends to impact both lungs, and that's usually what lands them in the hospital intensive care unit. And many of them do get what we call ARDS, or acute respiratory distress syndrome, and have lasting lung damage. In fact, I know several people who have survived, but because of the lung damage, many of them have to be on oxygen continuously. And one person actually is in so much pain that they're not able to work anymore, and they're actually wheelchair bound right now as a result of all the pain. It can also lead to sepsis and multi-organ failure, and also because of the overwhelming infections, they are more susceptible to other infections as well. And one of the things that we have heard actually is that for many of them, they do get fungal infections in the lungs after they have recovered from COVID-19. So a lot of complications to worry about. For children, as we mentioned, even with the increased cases, they tend to get mild disease, but sometimes they can also get multi-system inflammatory syndrome, which can be very serious and can actually even lead to death. Then apart from all of those really serious complications, there's a syndrome called long haulers, or where people have lingering symptoms. And what we've heard actually that this can occur even in people that end up just having mild COVID-19. So things like chronic cough and fatigue and shortness of breath, or brain fog or loss of memory are things that we've heard that can occur and last for, and even the loss of sense of smell or taste. And these can last for many, many months after someone recovers. Then of course, with the blood clots as well, we've had people who've actually had to have amputations as a result of blood clots in their legs or arms, and as a result have had, and all of this is a result of complications with COVID-19. So there's a lot to think about. And of course, this is all that we're trying to prevent with the vaccinations. So next slide. So hospitalizations, this just gives you an overview of the, and this is only for the last 30 days. And the reason we're doing it only for the last 30 days is that it takes us a while to compile all the information from the hospitals. The initial data that they give us just gives us the hospital count. But in order to get some of these details, we have to get the medical records. So I'm giving you only what it looks like for the last 30 days. But in time, we will be able to compile a total for cumulative hospitalizations. But again, it does show, I think something that has been of concern for us is the increase in individuals 18 to 49. They constitute 42% of the people in the hospitals in the last 30 days. In previous surges, it's been mainly people 65 and plus that have been been hospitalized, but this time around, it's 18 to 49. So some concern there because this is the age group that has one of the lowest vaccination rates and has the highest risk, because this is the age group that is working, that is out in the community. They're the ones who go to bars and parties. And these are places, as we know, that can increase the risk. Next slide. So moving on to some of the data about vaccinated versus not vaccinated. One of the questions that we asked is that, well, since people who are vaccinated can also get what we call breakthrough cases, what's the point of getting vaccinated? And this shows very clearly, and this is actually a slide that I got from our dashboard, so you can actually monitor ongoing. But the top chart shows, the red line shows for people that are not fully vaccinated, their case rate, and you can see it went all the way up to 70 per 100,000. The yellow bar shows overall, and if you recall, at the peak of this surge, our case rate went up to 45. And then the blue line shows for people that are fully vaccinated. So you can see that it remained really low for the longest time. And the highest it got to was 20 per 100,000. So this shows very clearly that there is protection from the that we get for people that are vaccinated. They're much, the risk of getting infection is much lower. And when you look at the bottom two, you can see vaccination status for cases and vaccination status for people who are dead. And again, you can see the stark difference in cases and deaths among people that are vaccinated compared to those that are not vaccinated. Next slide. As I mentioned, again, with hospitalizations, it takes us a while to be able to compile that data, but this is a slide that is actually on social media that UC Davis Health provides, showing the hospitalizations. And of course, it changes on a daily basis. So this was what they posted from August 30th, but it's been consistent throughout, where you see that for 80 hospitalized, 68 of them were unvaccinated. And even for those that were vaccinated, some of them, they were at a risk because they had immune compromised systems that did put them at increased risk. Intensive care unit, I want you to note that 0 of them vaccinated. For those on ventilator, 0 vaccinated. And for those on ECMO, ECMO is a system that is used in the intensive care units for people. Well, basically what it does is that it helps the person to breathe as well as actually pump the blood around the system, basically keeping them alive. So these are people who are severely, severely ill. And again, you can see that for the 2 on ECMO, 2 of them were unvaccinated. So again, showing the stark difference and the protection for people that are vaccinated compared to not getting vaccinated. Next slide. And this was a slide that was provided for us from CDPH. I think it was originally from the Washington Post. And on the left-hand side, it shows you infections, hospitalizations, and deaths for vaccinated compared to those that are not vaccinated. And you can see that by the size of the bar, what the difference is. On the right-hand side, it shows you that for infections, people who are not vaccinated are 8.3 times more likely to get an infection, 25 times more likely to get hospitalized, and 24 times more likely to end up with death. So the vaccines we know are effective. They are effective in preventing infections, effective in preventing severe disease as well, and effective in preventing deaths. Next slide. So this was posted by Sutter Health, and I'll just read it to you. We're hearing so many people filled with regret from not getting the vaccine, said Sutter ICU critical care physician, Dr. Vanessa Walker. She and fellow Sutter, well, she was doing an interview, but basically saying that many people, after they get severe disease in an intensive care unit, they are then asking, I want to get vaccinated, because they realize that they should have gotten vaccinated. By then, it's too late, because it takes a while for the vaccine to take effect. So when you're severely ill, the virus has basically overwhelmed your immune system, and the vaccine does not help you at that point. So our plea to you is, please don't let this be your story. Next slide. This is a letter that is posted on the Sierra Sacramento Valley Medical Society board. It has been signed right now by over 800 physicians. And again, I'll read it to you. It's pretty brief. Dear community, we are your physicians. You have honored us by entrusting your lives to us, as well as the lives of your loved ones. We are also your neighbors, your friends, and your relatives. We share with you a deep love of this region and of our community. Like you, we dream of a safe, COVID-free future. Please get vaccinated. We ask this from the bottom of our hearts. As your physicians and as the people with whom you have worked, played, laughed, and cried, we must admit we are tired. We will keep working, of course, but we are tired. We are tired of the suffering, the pain, and death that can be avoided by getting vaccinated. We have studied the data, and the data is what I've been showing you. And we have seen the benefits of the vaccination with our own eyes. Vaccines are well tested, very safe, and highly effective. Yes, masking must continue, especially with the highly contagious Delta variant, but nothing is as important as being vaccinated. You've trusted us with every other aspect of your health. Please trust us with this. We're not asking you to do anything that we have not already done. Please, for the sake of our community, the young, the old, and all the in-betweens, get vaccinated. And it is, as I mentioned, by over 800 and still counting. Next slide. So that's the end of my presentation. And so I will hand it back to Dr. Adeniyi at this time.
Dr. Kashire, if you don't mind, there are a number of questions that are in the chat. Please unmute yourself, please. Dr. Kashire? Dr. Kasire.
Yes, I'm
Yeah, she's here. Yeah.
Okay, this is Cecilia Ojingo. There are some questions that some people have asked that is in the chat. One is from Sister Sylvester Odalia. It says, is the data a compilation of the entire country, or is it just specific to the Sacramento region? And the second question is from Dr. Hunt. And the question is, what is the vaccination rate for the Native and Pacific Islanders?
So the answer to the first question is most of the data that I have shown you is only for Sacramento County, because that's the data that is reported to me. And so that is the data that I'm monitoring. But you will find that if you were to look at the state of California as a whole, it mirrors exactly the same kind of information that I have provided for you. Except the one slide that I showed you where it shows the risks and showed that for deaths is 25%, 25 times the risk for people that are not vaccinated. That's information, as I mentioned, it was provided to us by CDPH and is from nationwide data from CDC. And as for the vaccination rates for the Native and Pacific Islanders, I don't have it specifically with me, but I know that it is pretty high. We were very successful because we were able to target them specifically. And I think, yeah, thank you, Doctor. You've put it up right there.
Looks like it's around 72.5% now.
Correct, yeah. So among the highest, the rate close to what we have for the Asian community. And shows very well for the Blacks, 40%, Hispanic, 40%. So we still have a lot of work to do to get them up to what we would like, which is a 70% level.
Yeah, a lot of work, really. Yes, indeed. Okay, any more questions, please? Go ahead.
So while others are thinking of questions, I guess one other question that's come up, I know, I'm not sure if you're able to speak on this now, but I know LA County recently required or mandated that all children 12 and older get vaccinated in order to matriculate, I believe, in their public school system. I know Sacramento County hasn't done that, but how do you see it playing out in terms of increasing the vaccination rate within children going forward? Obviously, we want to increase the vaccination rate within our adults, but children are being more affected, and they are still vectors for passing it on to other people that are vaccinated and unvaccinated.
That's true. And the vaccination rate among the teenagers is about, I think, 47%. So it's also not where we'd like it to be. With being able to pass a mandate for schools, because there are so many factors to consider, we've discussed that, of course, with the health officers in the region, and we all felt very strongly that we needed to have some uniformity, and that as traditionally we have done for vaccination mandates, that it should be done by CDPH, and we definitely would follow suit with that. It's very difficult for us to do it individually, and I know LA Unified School District did it, but LA tends to, it's almost operates like a state of its own. I think it would be very difficult for us and for the schools to be able to implement and enforce it if we were trying to do it on our own. I know it's being discussed at the state level, but I can't give you a timeline as to when they will consider being able to have a mandate. They're also considering or waiting for the FDA approval for ages 5 to 11 as well.
Dr. Kassir, I certainly moved by the letter from your physicians, the physician group, and I've kind of given some thoughts with regard to maybe something similar from the leaders of the different African cultural faith-based groups to share in the community, and kind of use that as a kind of a plea, really. Any thoughts on how you think the utility of that may be?
I believe that faith leaders are very important. Many of them, especially in the African American communities, have been working with us in having vaccination clinics at their churches. And many of them have actually advocated for vaccinations to their congregants. In fact, one pastor said that she told all her congregation that no excuses, every single one of them needed to get vaccinated. And, they're doing it. In fact, one time we were talking to one lady about her thoughts on vaccination. What she said is, if my pastor tells me to do it, I will. So I think that faith leaders are very important in getting people beyond their hesitation, because we can give them all of the accurate information, but it's hard to keep up with TikTok that comes out with all kinds of weird information. And for some reason, it just catches on and people just believe it without questioning, even though these are people that have no medical background oftentimes, or the information they're giving scientifically doesn't even quite make sense, but somehow people believe it.
You think that there would be any value in maybe having like a public domain where you can have like a list of those pro-vaccine organizations or advocates in terms of faith and cultural groups as part of the public enlightenment, or could that be kind of a backlash, you think?
I don't think it would be a backlash. As I mentioned, many of them have been very public about their support. And especially, as I mentioned, the African American community. And in fact, even at the beginning of the pandemic, a group of the African American leaders contacted me and they said, we know that our community is already behind when it comes to health. What do we need to do to protect our community? And I've been working with them. We meet with them on a regular basis to discuss strategies.
Thank you so much, Dr. Kassir. There's another question for you from Kwame Tambo. And it says, I had a question from a relative in Ghana. The person had the first shot of the Pfizer vaccine, but that was about 3 months ago. There was no more Pfizer vaccine for the second shot at this time. Instead, they are offering JJ shots. Should she wait until Pfizer is available for the second shot, or should she get the JJ? And then a second person asked, what if we made our own TikTok videos about vaccines? Oh, I guess that one is not for you.
About the TikToks, I'd love it if people would be able to put it out, put out TikTok videos with the correct information about vaccines. There are a few out there, but definitely I think more would be great. As far as the vaccinations, I know that in general, especially in the United States, where there is no shortage of vaccine, we advise that you get the same type of shot as you got before. But in Africa, where only 1% of the population is vaccinated and many of them are not able to get vaccinated, I would say if you're able to get the J&J, go ahead and get it.
Another question that I had, I know that the FDA recently has approved I don't know if they're calling it I guess they are calling it a booster vaccine for individuals that are 65 and older. I don't know if you can speak to the rationale, or for some people, they're wondering, if I got the 2 vaccines, what's the point of getting another one? I don't know if you can speak to why that's important.
Yes, and the reason that had even been considered is that there are a lot of researchers, of course, that are looking at the effectiveness of the vaccine. And what they noticed, especially with the Delta variant, is that the effectiveness of the vaccine was reduced, and also especially after beyond the 8-month period. And what they found, and I think some of these studies were done in Israel, was that after getting a booster dose, that actually that put the protection back into the 90% range. So that was the impetus for the discussion about vaccinations. I have not yet looked at the details as to why the FDA approved it only for 65 plus. It's already approved for those that have reduced immune systems. I think it's a consideration of people that are at the greatest risk, as I showed you, for people that are 80 plus, the risk of death, especially for those that are not vaccinated, is in the 1,000s per 100,000. So that's a lot. So I think that was the impetus for it. And of course, this is information they're continuing to look at the data, and there might come a point later on where they approve it for everybody else. But right now, I think they were looking at those that have the highest risk of severe outcomes.
Thank you, Dr. Kashere. Another question came in again. That might be more for our communication specialist than you. It says, okay, is it possible to reach out to Black icons to speak about getting the vaccines, like Nicki Minaj? They have a lot of followers.
Yeah, a lot of people follow them, and even when their information is not accurate, it is picked up, as what happened with Nicki Minaj. Yeah, it would be great if we could have more people of that caliber that would talk about the value of vaccination. I don't have any connections. I wish I did. Maybe Beyonce can come up and speak for us.
Thank you so very well. You have done a lot already. Thank you for all the information you've given us. Thank you.
You're welcome.
And then my last question, as others may be thinking of questions, you had mentioned that we have those that are immunocompromised, and now those that are 65 and older. There had been a push, I want to say 6 weeks ago, that there was going to be the booster vaccine for those of us that have been vaccinated 8 months ago. Do you still foresee that being the case, or now with this new FDA approval for those that are 65 and older, do we anticipate that waiting a little longer?
I think at least, especially because usually we follow what the FDA recommendation is that might be delayed a bit. But what happens is the FDA puts out their recommendation, CDC puts out their recommendation. There's also the ACIP, which is another advisory body that reviews vaccination recommendations. And then for California, there's a Western States advisory group that also meets and discusses. So I think ultimately we will wait for all of them to provide us with guidance on that. But definitely, I think with the approval for 65 plus, that's a group that we're going to start with. I know there's a lot of people, especially in healthcare, that have been waiting and want to get the booster dose because with their job, they are at increased risk. But I don't know where that's going to be with the information that we have right now. So stay tuned. I guess we'll know shortly.
And I know there was a comment about icons and whether here or across the Atlantic. One of the things that we've been thinking about is maybe having some of these town hall series to include some of those icons as well. And taking the advantage of the Zoom network where we can get people across that may be both local and international. So any more ideas, definitely share with us. We'd be glad to welcome that and explore that. Dr. Kasire, I know one of the earlier times we talked about the African continent and, why is it that it has been spared? And definitely a hard time. I know, faith, definitely we cannot help but, say that amongst other scientific reasons or basis. But any insights as we're thinking about this message, as we talk to family members on the homeland and across, we see or hear parallels. So I'm kind of wondering how we can influence them and also have them influence us on this. And any insights you can share with us will be helpful as kind of a transatlantic, Pan-African approach, if you may.
Yeah, I know we've discussed that, and it's not unusual for these viruses to have that kind of variability from one area to another, where you have severe disease in one country and then another one, they're relatively spared. That's because of the way that the virus, whenever it replicates and it mutates or changes, and so you might find a very contagious. For example, what happened with the Delta, where it started off in India and it just wreaked havoc there. And because of the travel between India and the United States, that variant was exported here. I know that for a short time in Uganda, we did have a lot of people that were getting sick and several people died. In fact, I got to the point where I didn't want to open my WhatsApp anymore because every time I did, it was news about somebody I knew that had passed away. But fortunate for us is that that surge has passed. But I think what's important for people to remember is that because we do have people traveling back and forth, we can't assume that Africa, since it's been spared so far, that it will remain that way. And especially with the lack of services and lack of vaccine, it's important for us to make sure that they have the correct information and that when they have the opportunity to get vaccinated, that they're able to do that. I know that they have their own Zoom forums as well, where they're trying to provide the correct information, but I think it's a huge problem with social media and how quickly the wrong information is actually transmitted from different groups. But I think it's important for us to be able to provide them with the correct information. And that's what I do with my relatives. They send me their clips and I correct them. I tell them, well, this isn't true. You can't, get vaccinated and somehow are electrified so that you have the light bulb next to you lights up. I remind them, hey, what did you learn in science? How do you think that would happen?
And I'm sure you do it in a loving way to reaffirm them, because that's part of the challenge that we run into, is that sometimes some of the things that people may say to us, whether it be loved ones or people that we don't know, can come off as being ridiculous to us for in terms of everything that we've learned over these last year and a half. But it's something that at this point they deem as true. So figuring out a way to redirect them and get them back on the path of understanding is important. I guess one last question that I have is just, we had the original, then we had Alpha, then we had Delta, which has been wreaking havoc, and now we've heard about potentially Mu and Lambda. Is there like one thing is, when is this all going to end? But also, what do we know about some of the things that are coming down the pipeline? We knew that Delta turned out to be far more dangerous to us than previous variants have been. But is there anything that we know about some of the variants that might be variants of concern or consideration or anything of that nature?
So far, what I know is the Lambda has not been a dominant one. And so we're still watching, but it doesn't seem like it's something that will end up creating a lot of havoc. I do have to say I am concerned about the Mu. It's a new one, and apparently from at least the reports that we have heard, it might escape the protection that we have with the vaccine. So I think, and that's the danger, of course, with continuing to have these high infection rates in the community, because that means that the opportunities for mutation are much higher. We're continuing to watch. So far, there have just been a few cases in the United States. I believe we have had maybe 2 or 3 in Sacramento, and we are concerned, and we will keep everybody notified if we see any increase in those numbers. But right now, for Sacramento, by far over 80 to 90% of the cases that are being sequenced are the Delta variant. And we know that the vaccine is effective against the Delta variant. So I think we can only fight one battle at a time. So we're trying to fight the Delta and get that out of the way. I have no idea when this will end. I was so hoping that June 15th was it, but it seems like this virus has a mind of its own. So we have to continue to be vigilant. And that's the reason why we still have the masking mandate, because regardless of what variant it is, we know that the masking does provide protection. So we need to continue being vigilant with that as well.
Ngozi, can I ask a question, please?
Yes, please, go on.
Doctor, please, I know a lady that's less than 55 years old that took the Johnson & Johnson vaccine. We found out that for women below that age, they have issue with blood clots. If she needs a third booster, can she switch to either Pfizer or Moderna, or should she stay with Johnson & Johnson?
So right now, there is no recommendation actually for a booster dose for the Johnson & Johnson. So I think once we get more information, that could be something to be considered, but it's not being recommended for those that have received the Johnson & Johnson right now.
And is that in part because like it came out like 70 days later than the messenger RNA vaccine, so it hasn't been out as long? Or?
That's true. And the information that we have right now is that the Johnson & Johnson, the effectiveness is still pretty high. So no need for a booster at this time.
It seems to me, Dr. Wazi, I'm reflecting on Dr. King's, there's nothing in the world more dangerous than sincere ignorance, and and this conscientious stupidity, and I think that we who might believe in science can talk for hours about the efficacy of what we're doing, and yet if we don't address the variant more dangerous than any Delta, and that's sincere ignorance and conscientious stupidity, we're going to be here next year and the year after and the year after, because that to me is the variant, the X variant. And this is no longer just a Trumpian trope. You have, and I put Nicki Minaj and Busta Rhymes in there because to highlight this notion of sincere ignorance and conscientious stupidity. And we have to address this. We have to figure out a way that, at least in some of our geographic areas, people are unchurched and the church doesn't have the sway that it used to have back, you know, in the day. And you have still people who have, and I question whether some of these people are being paid or whether some of these people are being contrarians to give them more followers. And it's to the point where we really have to kind of call them out. And we won't be liked. It's really kind of mission central that how do you address sincere ignorance and conscientious stupidity? That's the question. That's the variant that we have to address. Because we could talk about science and the numbers are there. Doctor has done a wonderful job laying out the science. But we still have to address this notion of popular mythology.
Yeah. Yeah.
And until we do this, and until we get that crowd, that the in crowd, the woke folk, right? Until we get them saying in a unified voice, take this shot. You know, don't use my culture, and I'm very upfront. You know, don't use my culture as your excuse for not taking the shot. Don't use my history to justify spreading ignorance.
Mm-hmm. Yeah.
But it's very much a popular thing that we have to consider. This is a variant to me. This is the single most important variant in solving this, because clearly the science is there.
Mm-hmm. Yeah. And we'll talk about, you know, pandemic upon pandemic, right? So that's another type of the ignorance. And that's why, again, we emphasize education. And I think, you know, one of the topics for discussion at our task force meeting on Wednesday is exactly on that question. How can we get to those unvaccinated that may be reluctant? How can we get to them? So you raised a very good question, and we'll take it one step at a time. I'm hoping that we'll be able to touch people one by one, each one teach one. We may not be able to get all, but we'll be able to get some by what we do now. So continue to be engaged, continue to raise that passion, and I raise the questions. It's important. So thank you very much for raising that, Sam. Yeah, we'll try and come to a conclusion here, and then I was going to ask Dr. Kasire, how are you?
I'm doing well, thank you for asking.
And it's quite a lot, you know, really carrying the community on your shoulders. And like what Sam is saying, why don't they get it, right? I would say there was a member of the community I was talking to one time, not too long ago, and she marveled at how you were able to go from here to where the person was at the parking lot and get the person to go and get a shot. So talking about getting people where they are. She is certainly very, very admiring of your work and from that experience, but from Africa, you know, in a public place. So thank you for leading us, and we continue to have you in our thoughts and prayers, and you and your family. So that's it. How many months before you can get the booster? Dr. Denny, you will start a question, concluding comments, and then want us to recite our thematic slogan before we conclude? Dr. Denny, and then we'll have a closing prayer as well.
So in terms of the booster, it sounds like it depends. So if you immunocompromised, at least, and Dr. Kasiri can definitely correct me if I'm wrong, 28 days after you've gotten your last dose would be when you would be eligible for the booster. And there may be something different now with those that are greater than 65, but that's the initial indication. There had been talk about people getting another booster 8 months afterwards, after completing their course, regardless of their immunocompromised or immunocompetent, but that has not happened yet. But at least 28 days after the booster for those that met criteria as of the FDA and CDC recommendation.
Okay, thank you very much. Please join me in saying thank you to Dr. Kasiri. I really appreciate it. You can use the chat to express more as well as you feel. You've reached out. We'll continue to come to you and you respond. Thank you very, very much. On October 2nd, we will have, we're planning an outdoor event in Oak Park area, a way to reconnect in person safely, and maybe remind us that if we do what we have to do, we could even do more of it, but also remind us of the importance of that human connection, especially for our people. We'll use that opportunity to also remember those that we have lost since the pandemic. There are some testimonials and remind us again of the importance of doing what we must do about being vaccinated. And we hear from medical professionals one-on-one, not just the Zoom, in person, who will be present during that on that day at the event. Enjoy some African diaspora cuisines from different African cultures, and then have fun at the park on that day. So stay tuned. That it come as you are. It's 3 to 7 p.m. that day. You come and go and basically have fun and learn, and maybe also get some gift certificates and some T-shirts and other promotional items as well. So can you join me? We'll say Ubuntu, one love, save lives, vaccinate. Can we all say that?
Yes.
Ubuntu, one
love,
love,
save
lives,
vaccinate.
vaccinate.
One more time. Ubuntu,
Ubuntu,
one love, save lives, vaccinate. And final one, like really you on top of it. Ubuntu, one love, save lives, vaccinate. Please, thank you very much. Dr. Denny, great job again. Thank you very much. Our admin, Ms. Sojingwa, wonderful job. I appreciate it. All of you coming, joining us, participating. Please, thank you. Continue to spread the word. The task force meeting will be Wednesday next week, and the community health educators second training will be September 29th. So stay tuned for the information. And our new communication marketing specialist, Ms. Revin, joining us also this event. The Africa House Sacramento board members, great to see you, and all the members of the task force. Thank you very much.
Ernest, can we get a copy or Dr. of the PowerPoint, or is that something that is kind of kept private?
No, we can share that. We can get that out. Yeah.
Okay.
Yeah, thank you. Madeline, Ms. Rocker, thank you very much for joining us on track. Do great work as well in the community.
And also the video from this meeting will be shared via YouTube later today. So the link will also be sent out to you.
Okay. And I think the plan also is at some point kind of walking through, have some of these available on our website, the Africa House Sacramento website, so you can easily access them. There are some PowerPoints, other materials there, but we keep updating them with these PowerPoints So thank you very, very much. Can we get somebody to lead us in closing prayer, please? Whatever faith, whatever tongue the Spirit may move you. Any volunteers?
Everybody's quiet.
Yeah.
Okay, Lord Heavenly Father, we come together. We thank you for the gathering. We thank you for the information, the words, the knowledge that was spread. Lord, we pray for the people. We ask that you bring a special knowledge, a special understanding that this land may be healed, both here and on the other side of the Atlantic. Lord, we thank you for our leadership here, and we pray that you give us a love for one another, Ubuntu knowledge. And everybody said,
Amen.
all right.
Ubuntu, thank you very much. Remain safe.
Ubuntu.
Bye-bye.